further developments what we have made in the last 5 years, but particularly in the last 3 years. So one of the things which we achieved, and thanks to everyone here who contributed, is the quality statement. The quality statement talks about what should be the policies, what should be the direction of travel for the future, and I'm going to discuss that today. And it should be for everyone, starting from birth to the last day of life. That's what the quality statement is. So I would like to first thank patients again, and this has always been my first slide, and without that you wouldn't be here. But I'd also like to acknowledge everybody in this room, and also people who could not attend today or who are going to watch this program later. But there's so many other colleagues, so many other organizations who have actually supported us. If I start naming it, my 15 minutes is over. So that's the quality statement. So what does quality statement mean for us? So I'm going to make it very, very simple. The first part is the secondary fracture prevention. That's why it is called. So secondary fracture prevention remains the key in all of our lives. But is that all? We have to start thinking about the primary fracture prevention. So that is our aim. That's the objective, so that nobody ever get the first fracture. But how do we achieve that? We need to start somewhere. So within the quality statement we started, we'll start with people who are at most vulnerable, at a very high risk, like people living with dementia or those with frailty or very high risk of falling, hence having a fracture. And after that, we'll also start working with a high risk group. All those individuals, we heard about Jude's story today, and they have been having osteoporosis, but we didn't know that. We have people who are on steroids, rheumatoid arthritis, or many conditions which actually leads to the adverse or very poor bone health. So then we also think about the women's health. That's the agenda in Wales. And we must look about the women's health part here, and that's the strategy forward. And then finally go to all. You will be hearing about the primary fracture prevention from the 4 strategies from the speakers in the next session too. I can see my colleagues talking about that, how we reach them. But today, I'm just going to give an update what we have achieved in the last 3 to 4 years about this. So this is the story of that woman, which is between 50 to 60 years of age, had the first fracture. The first fracture doesn't stop there. It leads to the cascade of events. It's a silent condition. It keeps happening if we do not stop there. And that leads to the accumulation of comorbidities, which would have been easily prevented or avoided if we don't have that. If you look at the green little arrows there, without fractures, we increase that, and people live without comorbidity burden for osteoporosis. We can do that. So what do? When we see the first fracture, we need to work around. We need to see, is that pink color cast when we have seen, what have we done? Have we told that patient that you had a fracture because of underlying osteoporosis? Can we pick it up? Can we diagnose that? Can we be smart, clever enough? And that's what we have done over the years. And all the FLS Home Health teams in Wales who actually presented their work and their initiatives in the last conference, they are the one who has made the change. How they have made the changes? By working cleverly, working smartly, in collaboration with the radiologist, with the trauma, with ED. When a patient has come, pick up, identify. Don't wait for somebody to refer. That's the old approach. Work very much in a proactive but reactive, integrated way. Pick up those fractures, and this is what recent MAC report has been told, which we'll hear about the session 4 today. So once we are very active, proactive, we identify these patients, we don't need a referral from a primary care or a trauma or another surgeon who are busy in their work. Let them do their work, and we will do our work. And as a result of that, what you heard from Craig earlier, that look at the spiraling event of that, how we can quickly identify these patients now. Once the identification is done, half of the problem is resolved. We go to the next phase of providing the treatment. This is like diabetes, I shared the example. If you do not diagnose diabetes, you just end up having an end organ damage. So don't wait till the last part and identify this. So that's the first part. But if you look at the orange line as well, that is about the DEXA scans. So we are making progress. We are not there yet, but we have a lot to do. But we have been able to provide more DEXA scanners in spite of the fact we have doubled the number of identification in Wales in the last 1 year. So that's something we should all congratulate ourselves. This is the slide which is available. I encourage everybody, if you haven't seen, if you type FMS reporting in your whichever search engine you have, and start looking at this where you are with your health board. Do not compare one health board to the other health board, please. Just see yourself and then start looking where you are with a national benchmark. So national benchmark or go above that, that should be the key. So this will show what the KPI or the key performance indicators we have done. The KPI 2 is about the non-spinal fractures, which hip, wrist or humerus. So if you look at this, it's aligned with a national achievement now. So national benchmark and Welsh benchmark is almost same. But we'd like to improve more on that, and we should reach 80% on that. The second one is about the spine. So spine fracture identification is better in Wales because we have a better links with radiologists, and they look at the scans, they give us the word fracture, and we start identifying those patients. And also research also support that. I'm sure Qasim will talk more about the fracture identification for the spines. And have you seen them within time frame, which is 90 days? And our put a tick is Amber is there, but we have to do more. Because when you're having more demand, are you able to provide that care within recommended time of 90 days of care plan? So that's a tick, but it needs to be 80%. That having provided the medications to them, more patients diagnosed, but we're still providing those medications to them as they need based on the evidence, and make sure it's done. Where we are not doing very well, these are the two things. One is the DEXA scan. So we have to provide more DEXA scans, and we'll hear in the talks later today that how we can improve our DEXA scan services. We do not have funds, and I cannot keep asking colleagues to give me more money, because if I ask for more money, I'll be out of my road, and I cannot afford that. So the second part which we have to work is the adherence. So diagnosing diabetes, giving medication for first 3 months and forgetting about that is not going to resolve the problem. So diabetes is a long-term condition, and so is osteoporosis. We have to treat these two conditions exactly the same, what we have been taught in our medical school or any other healthcare profession. We can't just leave it there. So we need to provide longitudinal integrated care to these patients. Otherwise, how will you manage after 2 years, 3 years? These patients will be coming back to the different door. We can't afford that. So hence, fracture-related services should be working with many people in the community. Pharmacies, just one of them. Primary care GPs is another one, but also all health teams, rheumatology, a lot of other colleagues which will work together on that. So I'm going to share the example of pelvis fracture. The pelvis fracture is something which we have identified more. This is only data from one health board. But look at the pelvis fracture. What is happening if we do not identify them? They are there, and they're quite old patients, and 2/3 of them require hospital admission, and they are lost. There is no such report for pelvis fracture. They are spread across all of the health boards, rehab boards, general medical boards, and nobody owns them. But if you look at this, the previous fracture is already present in more than half of them, and now they're hitting our hospitals. And look at the length of stay, 30 days. But when we start comparing pelvis fracture to the hip fracture, it's exactly the same length of stay. And that's the mortality. It's serious. Same mortality for hip fracture, same mortality for pelvis fracture. If we do not identify these patients, how will we protect them from dying in our hospitals or staying up to a month in our hospitals? So as a result of this, Anthony has been really supportive of this and carried on this with us. And what we have is now pelvis fracture included in the National Hip Fracture Database, so that at least we can do what we can do and see where we are heading in the future. But Wales is leading the way here. I'd like to thank the District Healthcare Wales and Sally Cox who have supported me with this. We have this database for Wales now. So that was the hard work in the previous slide. This is the clever way. When we all patients coming in, it depends on coding. When you have the coding, you're able to see that. You're able to see the gender differentiation of the pelvis fracture. You're able to see what level of comorbidities they have, where the patches, where the heated area in Wales is. You can see all of them. But you can also look at some of the health outcomes. Now, when I met CMO in any meeting, she wanted us to give more health outcomes. We have available now on our fingertips. Read data rich, use the data to knowledge. So no health board should be looking at it, how we are performing. They should be looking how we are to implement these services. That's the key word for me, that these services are available and there is no regional variabilities of these services. By just looking at this, you can actually see that mortality for the pelvis fracture is not only in old people, but look at the younger people. Between the age of 60, 70, they still die with pelvis fracture in the hospitals. The median length of stay for them is still coming at 17 days. How we manage, how we work collaboratively to with all the hospital teams and get these patients identified and treated what they want. On this note, I'd like to thank my colleagues in the digital healthcare base. Without them, we would not have achieved this. So, and I believe they are in the room somewhere, and it's big thanks to all of them, and without this, we will not have this dashboard. This dashboard is yet to be launched formally, and I'm waiting to meet CMO and the other medical directors for the final approvals. Then, part of the pharmacist. So we have those initiatives. We have been supported by the 6 goals in the beginning. They've given us some money. Looking at the effectiveness of the pharmacist. Pharmacist is not another person who will just identify and call and do this. Pharmacists bring more skills to the MDT. Their skills, how to manage drugs, how to explain the things about looking at the other parts of the drugs, but how to make it more connections in the primary care community. So based on that success, we also have seen it's very cost-effective prescribing if you have pharmacists in team. So many teams in FLS now have pharmacists, but we want to make it as dedicated as part of the business cases so that they are ring-fenced within the FLS, not coming from just as a support from the division. So that's something we are currently working on, and we want this to be embedded. So after the success of the first pilot, we have been receiving more money, and I'd like to thank my colleagues in Welsh Government, Karen Flora, who has been behind the scene to get us initiatives here, and how we can see, can we make the change? And we have made that, and this year we have received this small little money, but it does help us to see that can we prove the concept or not? And you'll hear more from my pharmacy colleagues later in the day. Now, what about the primary care? We need that support in the primary care. The person who had fractures, there is little less evidence for the risk factors, but there are some risk factors we can change, modify, cataract, and again you will hear this later. But I'd like to thank Charlotte, I think she's in the room somewhere, and she's been the woman behind this, and we have actually managed to achieve this, and this will be available, I think, in the next few days, and this can be used for those people in the community, how to mitigate those risk factors. Alongside, we also have a community health pathway for osteoporosis. So when these patients are after 52 weeks, or those who have not had fractures, primary care colleagues need some sort of guidance and how we manage to refer them. So that will also be launched in the next few days. So this is about the patients, the PEM and PROM. How we look at what is the evaluation coming from the patients, what are the outcomes. So we have made huge more progress on that, and this is gone very digital now. We're able to see these type of graphs more in the future, and they're able to see what is the change of those. So less of red, and if we keep moving the shift towards green, so that more people are more independent, they're having the healthy lifestyles, they are not able to stop smoking completely, they can seek help, they can self-refer for the physiotherapists, or they can just follow the guidance from the physiotherapists of societies to see how these exercises can be done. So that's all work is going on, and I'd like to acknowledge Dan, Sam, and Christina to their support on this. We still have a huge lack of osteoporosis awareness, and we know this is an unconditional impact on our patients. But it also, we know that if we do not have adequate health literacy, it leads to the poorer outcomes. So those patients come to a hospital, stay longer, and also at risk of that. And you will see the evidence at the bottom. If we do not adhere to the drug, it does lead to more problems in the future. So we have a team, and we have EPP covering team, which is somewhere in the room here. So we link them together, and we worked on that and see how we can actually provide this. So Jules and Christina is in the room. Please visit this and don't meet them. They actually done a wonderful thing here for us. We have done the pilot. It's not living with osteoporosis, it's living well with osteoporosis. And you will hear more about what they have done. So this program is now successful, and it will be business as usual in the next few days, and I can see Helen in the room. So well done. So what are the areas of focus for us in the next year or many years to come? Yes, we have to improve our access to DEXA scanning. Yes, I agree with Craig, we have to improve our adherence to the drugs for the 52 weeks, and that's where we need help from. But also longitudinal, long-term care. It has to be integrated care. Without providing the long-term care, we won't be able to manage osteoporosis in the longer term. So we have to work more collaboratively and more in partnership for the future to come. We also need to think about sustainability. Are we actually providing a sustainable care or not? And we're working with a college on that. So if you'd like to read the story with the college, please do read at the bottom. And I'd like to end here. That is a collaboration and partnership with all of you. And that's the only way forward. And thankfully, in spite of we have a change of the government, my colleagues sitting on that desk here managed to get this included in the NHS Wales technical planning, and ROS supported us for this as well. So we have a plan, we have a policy, and we have a will to make the change, and we're going to go our level best. That's all from me. Thank you for listening.